I'll let the panel introduce themselves in just a second, but just by way of context, I guess, and this probably doesn't need saying in this room, but we're at an extraordinary crossroads in the history of the NHS. We always seem to say that, but it's always true. It's absolutely clear that, from the 10-year plan in particular, the question is no longer about whether technology has a role to play, but whether we're treating digital as a superficial add-on or, alternatively, as the foundational architecture of a reformed health service. That's not a leading statement at all. So over the next 40 minutes or so, our job, we're going to look past the slide decks. We're going to look past the press releases. We're going to look past the overblown LinkedIn posts. Not all of them are mine, but we'll look past those. We're going to honestly answer, with some humility, the core question, is digital materially reforming the NHS, or are we overstating progress? And so, as I said, to do that, we're going to have a really focused, completely candid, unapologetically impact-led conversation. And we're going to try and frame it over 3 lenses. So we'll talk first about impact, so our kind of glass half full bit, what's working, what's changing care delivery at scale. We can't have this conversation without also talking about the tension, what is failing to scale, what are the friction points that hold us back, why do we fail to scale often? And then what's going to change? What has to fundamentally change in our infrastructure, in our procurement, in our leadership, in our workforce training to support a future of digital across the NHS? So we have Sara, we have Claire, we have Ming, we have Tom. Before we kick off with questions, I'd love you all to just introduce yourselves to the panel. Sara, we'll start with you.
Thank you, Richard. It's great to be here, everyone. Sara Siegel. I'm from Deloitte. I am our global healthcare sector leader. Despite the slightly confusing American accent, I have lived and worked here for the last 20 years with the NHS, so I can definitely engage in this conversation with lots of experience of working with the NHS, as well as perhaps a few observations from primary care systems and digital advancements abroad.
Lived here for 20 years, but didn't bring an umbrella on the 2nd of June, so you've obviously not quite got the UK memo.
But really wanted to be here because I cycled for 45 minutes
Absolutely.
In the rain to get here.
Thank you so much for that. Claire, we've all met you, but anything more you want to say?
No.
Thank you. Ming.
Hi, everyone. I'm Ming Tang. I was the Chief Digital and Information Officer for NHS England. Left in April, feeling great. Really happy to be here.
And lastly, Tom.
Hi, I'm Tom Ratcliffe. Thanks for having me on the panel. I'm a GP. I do my clinics in West Yorkshire. I'm a partner with Modality Group. I've been leading our digital transformation programme across the group for the last 4 or 5 years. I'm also medical director for our group of 8 practices just outside Bradford.
Thank you so much, Tom. So as you can see, stellar panel. We have a huge range of expertise, system leaders, national leaders, global leaders, frontline leaders. So really rich conversation going. Sara, I'm going to start with you. So we're going to start, as I said, glass half full. What's working? From your global vantage point, what separates health systems that are genuinely transforming their models from those who are perhaps just spending money turning paper processes into PDFs? What's the secret sauce that really makes systems fly?
I think the secret sauce is the structure, and I think the good news is that the structure, kind of the bones of the system we have here, is the right one. So if we look at the systems or pieces of systems that are the most successful around the world, they are ones that are set up to look, to use your words from your last fireside chat, Claire, at the whole person throughout their whole lives. And obviously, all of our systems were set up to be episodic, so this isn't a natural motion for any health system. But again, in my global travels, I was very lucky to be in California a few weeks ago, and I got to interview the medical director of Kaiser Permanente. And they are not a whole system, but they are a subset of California and parts of the Pacific Northwest that are set up in this way. And he's able to list off stats about how their costs to serve per head of covered population is much lower than their competition. And then even more importantly than that, he lists the outcomes that they get. So they measure healthy life years, which they have much longer healthy life years than their other competitors. They have lower rates of death from all of the major long-term conditions. And the things that he points to that they've been able to do to help with that are really simple things that actually we could do here. So it's things like when someone's in for a podiatrist appointment, they can see on the system that they also are due a mammogram or a blood pressure check or something else. And they can say, I'll just book you in now. When are you free? And the text comes to the phone and it's agreed in person with the patient and they've checked that the travel works or they can do it remotely. Like any clinician touching a patient in any way at any point in time can see the entirety of what's going on with that patient and can just quickly fill those gaps. Now, we have not solved that problem here, but we are structurally in a place where that is possible. And if you look at lots of other systems around the world, they don't even have the governance or the organization or the data to be able to do that. So despite the fact that we have struggled for the whole of the 20 years that I've lived here with joining that data up, I too am very hopeful and feel that we are closer now than ever to being able to have that kind of a lens and to be able to support a citizen, not even a patient, in a more holistic way, in an easier way.
That's really interesting. And just staying on the Kaiser example, well, I understand the data architecture, the infrastructure that allows that kind of holistic viewpoint. Are there any, and you may not know the answer to this, obviously, you're a Kaiser proxy right now, but are there any incentives or other types of directives which also then enable those conversations to happen? Just thinking about, data infrastructure is one thing, but culture is another. So why is it important to a Kaiser clinician to make sure that anything that can be ordered can, the patient's in front of me, what else can I do? How do they drive that culture?
That's a really good point. And it's also probably worth saying that, they've had their workforce challenges just like every health system has. They've had difficulty paying at a scale that keeps pace with inflation. And that's been a challenge in the UK, in the US, and lots of developed countries since COVID. They've had strikes of their nursing workforce. Like, it's not all sunshine and roses out there, although the weather is really good compared to today. But what I would say is, and this is another thing the medical director was saying when we spoke, basically, when he goes to report to the Kaiser board, which would, I guess, be the equivalent of some kind of an NHS England board, he's reporting on all of these outcomes metrics. So, what proportion of our patients haven't been in for their regular prophylactic screenings of X, Y, Z things? He's held to account. And so that objective for him flows down to all of the clinicians and all of the different medical departments. So they are all basically measured and incentivized to not just, the podiatrist look at the feet, but to check all of the various checks.
Yeah, thank you. Thank you for that. It's really, really interesting. Claire, I'm so conscious as chair that we've only got you for a limited amount of time, so I'm going to come to you next. Your point about Chris Ritchie's point really resonated from earlier. I mean, what's missing? Because it's something we find a lot in the Health Innovation Network as well. There's sometimes an inability to see success or to value success or to say, well, that's fine, but it was last year. It's always about the next. And actually, when it comes to innovation, perhaps also seeing innovation as the new rather than just we've not done it before. It doesn't matter that it's something maybe it's been in existence in healthcare for 20 years. If you're not doing it now, it's still innovation to you. How do we get people to, I suppose, to be proud of what's happened, to keep the flame burning almost, to say this is still something to talk about, this is still something to broadcast? And I guess, is there anything that is missing from our national architecture, perhaps? That's what got me thinking about, almost like the Museum of Success type of idea that would help us to do this better.
So in my Surrey job, I remember getting so I had different leadership positions across Surrey for about a decade. But in the last sort of 4 or 5 years, I went through a real arc of at that point of feeling really nothing's getting better, everything's terrible, and made a realization that because of the type of work we do, it is that every time you fix something, you see the next thing that you have to fix, and so you constantly feel that you're not doing very well, and it was almost a learning to embrace that system and actually going around the systems that are the highest achieving are probably those that don't think they are, because they've got that real hunger to do things better and they're not complacent. And often some of the shinies that think they're great are kind of like, well, no, we're really good, we do it like this. They're not. So there is a cultural thing that drives innovation and drives improvement that is about that constant desire to keep making things better, keep spotting the next thing. So I think there's a cultural thing for boards to think about in terms of, if you think you're doing really well, you're probably not. and a bit about permission for us to be kinder to ourselves if we don't think it's going well, because actually it may be going better than it is. And I think that's part of my role, particularly in going. I'm just seeing Brendan over there from West Yorkshire. We were there last week. But part of my role is to actually hold that mirror and go, actually, do you know, you're doing some really great stuff, but you don't know that you are. Yeah. And then going and sharing that. So, we've got the NHS Excellence Awards, haven't we, that we're giving for the first time at... are we still allowed to call it Confed, even though
it is officially, for 1 year only, Confed Expo next week.
It's still Confed Expo, yeah.
I've had that from John,
okay, so
tablets of stone.
Fine. So
Not sure what we're going to call it next year.
No, but we're all right this year.
This year's fine.
So at Confed, we've got the first NHS Excellence Awards being handed out, and I judged the neighbourhood entries, and they were absolutely brilliant. So each region, had a winner in each one of the sections. But again, when you see the amount, there is definitely something that we should get better about celebrating, and that's part of the NHS Excellence Awards. I think we've previously done it through HSJ Awards, but I think it's holding on to that culture of sometimes we do need to look back and celebrate what we've done rather than constantly striving.
I think the celebration thing is really, I'm really passionate about that. 15 years ago, when I was a slightly younger NHS manager, I created something called the NHS Innovation Challenge Prizes, which is exactly the same. They were born out of Innovation, Health and Wealth, and Innovation, Health and Wealth absolutely identified some of the barriers to this is actually just staff recognition and reward, and think about how that manifests itself in the public sector as opposed to the private sector. I think so the Excellence Awards, I think, are a fantastic continuation of that, but perhaps we need to be doing more of that at local level as well.
It's a Don Berwickism, isn't it, that one of the things that drives people is actually people go to work to do a good job, and part of my role is recognition of that. So that's on the visits, trying to make sure always that we highlight the good things that people are doing, as well as slightly push people on to kind of go, but you're doing this brilliantly and you could do this as well. But there is an importance for the NHS centrally to recognise the good work when it's going on.
Absolutely. Tom, let me come to you. So you lead digital for 500,000 patients across Modality. Let's get into examples on the ground. Give us an example, a stark example of a digital tool that's measurably saving clinical hours on the ground. If you had to say, this is the one thing in digital that changes my practice and the practice of my partner GPs, what's the thing you'd point to?
So, it's always interesting. The first thing that we all need to do is completely ignore all statistics on people's flashy PowerPoint presentations, because it never quite plays out like that in reality. And if we added up all of those time savings, none of us would have any work to do, which is definitely not the case. I think there are a lot of things that made a difference. I think if you spoke to our clinicians, they would probably say that ambient scribe is the thing that they like most in terms of digital technology, and it saves time. Certainly for some clinicians who spend a lot of time generating notes and letters, the time savings is significant, and the benefits for those clinicians are significant in terms of their health and well-being. But I think the thing it probably does most is allows people to be more present in the room with their patients. So it's not always about time saving. I think in many cases it's improved the quality of the interaction with patients. So I think if I was to name one thing, that would be the thing that our clinicians would tell us has had the biggest impact.
And I think that's probably expected, I think, in terms of how AVT and ambient scribing has really taken off. Do you have any insight or any kind of personal thoughts on why that is so? Is it just it hits so many buttons and ticks so many boxes in terms of both, clinicians love it because it actually solves a problem that they have, patients love it because it actually changes their experience? Is it as simple as it just does what it says on the tin? Is that why adoption has been, for me personally, in a leadership role of all about adoption, I think it's unprecedented in terms of how it's scaled organically. I can't think of many things that have done the same.
Yeah, it's very ground up. I mean, we when you're normally doing change in the NHS, it's a painful journey just getting people to adopt stuff. But it was completely the other way around with ambient scribe. We were saying, please just slow down. We need to get the governance right. We need to make sure this is safe. We need to make sure our data is handled properly. So there was a clamour for it, and I think it's because it just fit into the sort of flow of people's days and did something that was genuinely useful to people, rather than people actually necessarily having to fundamentally change what they were doing.
Yeah, thanks, Tom. Ming, I'm going to come to you, and I'm going to move us on to the, maybe slightly glass half empty section. But before I do, I don't want just to give you the negative. So, just to give you a bit of a time first, is there anything you'd add to the conversation? What, from your perspective, from the senior job you've just completed, what's working digitally in the NHS right now?
I think we have spent so much time putting in some of the foundations. I think the optimistic side of me says, actually, we've now got an opportunity not just to do more digital. I think that's something that we should actually think about. What do we want to change? So if you can link up what the transformation thing is, and to add to Tom's point about AVT, it works because actually it helps you do your job differently without having you to force you to change because it's what the system says. So if we can look at, with the advances in AI and the agentic AI going forward, what is the role of work and how do we put those things in combination as an augmentation piece? Yeah. I think that's the positive stuff. And we've spent the last 20 years putting in the foundation so that we can actually do some of that. So it should be quite exciting for us to actually reimagine what is a flow in, whether it's neighbourhoods within a GP practice. How do you want to handle your processes so that you can make the most of the technology rather than the technology's doing this and you have to change your practice? And I think that's decoupling those two things are really important. So I think that's the exciting opportunity we've got if people can embrace it.
So let's flip. Let's go on to, so where are our tensions, where are our frictions? I'm going to stay actually with agentic for a minute. One of the things that we find on the National Commission for AI is thinking about not just the 2026 scenario, but how one regulates for agentic AI in 5 years' time, in 10 years' time. Who is responsible for care when you have agent upon agent running different agents, and perhaps a bit more of a black box of spitting out an answer, but nobody knows what's in the black box. I'm not asking you to solve that wiki challenge, but I guess in terms of where digital data and AI may run into roadblocks, how are we doing enough to bring all our NHS staff and our population with us? And if not, what else? What's missing from that conversation?
I think the answer to that has to be no, because there's so many people that have gaps in knowledge and the technology is changing so rapidly, right? So I think one of the considerations I think we should be thinking, in line with changing what you want to do as a digital transformation, is actually thinking about how you're going to apply those agents. If you just use agents because you can get rid of people and you're going to have thousands of agents available to do things faster, but it's the same stuff, that's a total waste, and that's when you do end up in that black box situation. If you think about it more carefully, what are the generic roles that agents can play and how they help the human do their jobs more effectively? And then what personas those agents should be taking. So you could have a persona of an agent that really investigates. So your PACs, for instance, go and investigate and bring back all the information that's necessary in order to do this task. You have another agent that actually is interpreting with the person, helping with, whether it's a clinician or whether it's an operations person, that actually helps you think through, and you can prompt it to ask more questions about, okay, if I did this, what would happen? And you can build some of those, simulation scenarios that then helps you augment your intelligence, and you can do more with that. And then I think a really important persona for an agent would be the checks and balances. So in every process, you should have a check and balance. And if you could design an agent whose job is simply to do that check and balance, it makes it less of a black box. It makes much more transparent. And you've then got the oversight, and you can have that log of what's going wrong in the process or how you can improve. And then, I think we are still human, so we still need to bring all that stuff together and actually have a discussion about what do we want to take next and how do we want to do that. So I think half empty would be, if you don't put some of those checks and balances in place, we could go down the track of automating rubbish. Right? It's rubbish in, rubbish out. Just because you've got agents, you're going to do it much faster. It's going to be a nightmare for the human to keep up.
Yeah. Sarah, you wanted to come in?
Yeah, just to maybe share like a few little vignettes to highlight what I'll call the dissonance of the point that you've just made, Ming. So on the one hand, I've been lucky enough to sit on the MHRA's commission to think about how they're going to regulate AI, and I'm on the subcommittee with all of the tech vendors, which is a really interesting group. So I get to sit and listen to Apple and Anthropic and EMIS and everybody say, all we need is like open APIs, and if we gotta just use Fire 7, then we can do everything. And they're running. They can see all of the clinical pathways totally automated, and it's perfectly linear in their minds. And without humans, I suppose that could be the case. But what is not in that subgroup, which is by design, is real contact with the service. And I know that they have real contact with the service outside of that. But that's kind of one I think of this as like fast and slow. That is like the fast lane on the highway. And then, to counter that example, I was sitting at a workshop with one of the NHS regions yesterday, talking about a broad digital program and all of the opportunities that AI and other tools presented, and just saying, how should we go about this? What are we going to tackle first? And that was a discussion which was very much trapped in contact with reality, where everyone was saying, love this, want to do this. Here are the 10 things that are in our way that are going to keep us from doing that, which are real roadblocks that we have to consider and get around. And so while the technology exists today, you can't just snap your fingers like Dorothy in Kansas and it's there. And a real example of that is we were with a big London teaching hospital talking about outpatients. And we were saying, okay, we have all these tools to reform outpatients. They drew out, the laborious outpatient process for one specialty. And we said, okay, let's just look at this and think about, what do we want to change? Well, we could take out this, we could take out this. And then they're like, screw it, we could just cross out the whole thing. We shouldn't be tinkering with this process. Yeah. We should just say, what are the actual clinical requirements? And what are the tools that we have? And just think about what it could look like in the future. And it might have none of these process steps in it. And that was a really positive conversation. Yeah. But to get from that conversation to an actual reimagined outpatients process, again, it's not Dorothy in Kansas. That is going to take some serious time. And there are a lot of clinicians who would like to imagine that future, but who have been practicing in the reality for 20, 30 years. And it's going to, we have to deal with the humans and the machines, as you said, Ming.
Yeah, absolutely. And just staying with that outpatient example, what do you perceive as the biggest friction points and barriers, moving from that design vision to actual implementation? Is this finance and funding, procurement? Is it clinical buy-in, patient aversion? What's the biggest hump in the road?
I think that the clinicians are the key to everything. I think that the most successful programs are because of clinicians, and the ones that fail are also because of clinicians. And I'm not saying that every program is a good idea, but I think, maybe going back to the AVT analogy, the reason that AVT is taken off is because clinicians wanted it to take off. Every other AI technology that I had spoken to a clinician about before ambient voice, they were opposed. They were worried that, AI is coming to take everyone's job. But when AVT came and it took away pajama time and admin that every clinician hates, the story flips. So I think capturing the imagination of clinicians is the key to reforming outpatients. I think if we take a relatively low acuity, non-complex outpatient process and start there, hopefully one where the patients don't have too many other comorbidities, and you do something radical and you see it with your own eyes and you can touch it, then everything is possible.
Thank you. Claire, coming back to you. Let's talk about pilots. So okay. we often say the NHS has more pilots than British Airways.
We're a lot bigger than British Airways.
We are. But from a national perspective, why does brilliant local innovations consistently hit that brick wall of scale when it tries to scale from one organisation to the next, or sometimes even from one ward to the next? Is it risk aversion? Is it cultural? What are the barriers that you see from a national perspective?
So I had to do a health select committee on the NHS and approach to pilots. And a lot of it actually comes down to how we describe a pilot. So sometimes we talk about pilots as being when we are deliberately scaling. So if you look at the introduction of fit testing, that started as a pilot and has been brilliantly scaled across the whole of the NHS because it's clearly defined what the product is and then we're going to, and then the rollout and was funded, and then it went all the way across. When people talk about NHS pilots in a negative way, actually, those pilots are about policy testing. So if you think about and that's why they don't always get scaled, because you're testing the policy, and then you then write the policy that then leads to the systematic spread that happens. So one of my favourite set of pilots is the PCN test site pilots. I don't think there's none of the gang in, are there? There's 22 PCNs across 7 ICBs, and we took a slightly different approach to pilots with that group. And they had a set of money with no parameters. And it was basically, let's see what you want to do to make it better. And we audited them every 2 months, looking at their access, their patient satisfaction, the improvement in their quality, and basically what their teams were doing. And that program's been running for 18 months to 2 years. And actually now, as that's coming to an end, we're now working with those sites and their ICBs, but actually they're making the business case for the investment that has gone into those practices, with the resultant change and impact on the rest of the system, to then enable those ICBs to then scale across it. But the bit that they've done in those pilots has been, it's not been the rollout of, like the fit testing, the rollout of a set thing that's gone. It has been, what we've seen is that they've changed, and they've constantly changed, which is why you wouldn't say, how would you roll that out? Because actually where they're all going to end up is very different from when they started, and actually it will continue to evolve and change. So if you think about AI and digital products, most of the sites have gone through 2 or 3 different triage models, different tech partners, and have evolved and have changed that model from either starting very doctor heavy to being more tech heavy, to then actually changing it how it goes. So that, although they're pilots, they're actually quality improvement projects. So I sort of haven't. We are very. I think we are a little lazy in our terminology of pilots, which is. And if you do the civil service definition of it, then it would be like the fit testing, which is we've got a thing and we're going to scale it. When we talk about pilots, we're not talking about something that we're planning to scale. We're talking about making improvements that is then going to inform future policy, that then lead to a rollout.
Interesting. Do we need to change some language?
Yeah. And then you see sort of the neighbourhood framework then gets to be, that is the change in the policy that then enables people to actually then roll it out.
Okay, thank you. Tom, coming to you on this section before we move on. So you mentioned in your intro, you see a lot of the reality, obviously, as do many people in the room, versus the press release. From your perspective, particularly thinking about your role across modality, is there something... Could you talk to me a bit, I suppose, risk appetite? Because I think that's often cited as one of the reasons why the NHS is seen as slow and low globally, etc. Is there a conversation at modality? Is there an awareness and I suppose an intentionality about your attitude to risk? What do you think about? What do you contemplate when you're thinking about implementing digital technologies at scale?
Yeah, I mean we are fortunate in that we're an organisation where and I guess this is quite similar across a lot of healthcare, where the person who is implementing technology is also the end user and can quickly see when things are going wrong. And we have set out to take measured, carefully considered risk, because otherwise you can't digitally transform at the pace that we think we need to, and you'll always be behind the curve. So I think we need, and we're unique, and there are other at-scale providers who can do all the governance and the safety checks and the monitoring that you need to do to roll out technology. The reality for a lot of primary care is they won't know how to do the governance properly. They won't know how to do the clinical checks. They might mess things up in terms of the legal requirements for safely rolling out tech. So we're in a position, once we're happy with that, then we're prepared to take a measured, considered risk and monitor things, and we can roll it. But I think that's difficult, and it's because we're on the glass half full section of the panel. I think that's probably now more difficult because the people that primary care would have turned to in the ICBs are no longer there. IT teams have been wound down. DPOs, getting hold of your DPO is harder. There isn't the clinical safety officer input that you previously had access to. And then when we move to share data controllership, no one's quite figured out how that's all going to work. So it feels like we really want to accelerate digital transformation, but who's going to help primary care manage the risk properly outside at-scale providers like Modality? I think that's a bit of a problem.
Thank you. We're going to wrap up soon, but I do want to get to our third section, so we're going to cover that quite briefly. But the third section, if just to remind people, was so what needs to change? And actually, some stuff's been identified already. But let's finish there. So I think we've got just to give you some. I mean, the levers in my head. There's always a lever around workforce and upskilling and training workforce. There's a lever around prioritisation. We can't do everything at once. So can we actually prioritise within the NHS? Funding's always in there. Regulation's always in there. You may want to pick one of those levers. You may have your own lever. But I guess, just to finish off the panel by just giving our audience an insight. One from each of you, please. So some of you will get more thinking time than others. But what's the lever you'd pull? Why? And how hard are we going to pull it? So, Sarah, I'm so sorry, but I'm going to come to you.
I can do it. This isn't exactly one of your levers, but it's a mix. I mean, incentives, like speaking to an audience of primary care, you are the perfect audience to talk to about this. When QoF was introduced, I think the average attainment was 96% across GPs within, a matter of months. When people are incentivized to do something, not just GPs, that's human nature, right? We do it. So I think that is just what needs to align here. And if I use Claire's pilot example to sort of lay this out, when we do pilots, we fund the pilot in many cases. We fund 6 months of something. We don't say, we're going to incentivize you to change the care pathway, fix the governance, and make this part of day-to-day business if it works. We don't set that all out at the beginning. So then, when the pilot's over, if it worked, you're at ground zero, writing a business case, convincing the leadership, thinking about how the processes need to change. It's impossible. I'm the trustee of a charity that funds innovations in the NHS. And we gave a little bit of money to fund post-surgical wound care at home with a little bit of good tech from a big London teaching hospital. Oh, it was amazing. Patients loved it. Clinicians loved it. Beds were freed. Infection rates went down. Readmits went down. There was nothing bad to say about this, except that it hadn't been prepared with a runway for success and building into the process. Yeah. And we literally had to go to the trust board and say, hello, do not stop funding this. We're a charity. We can't fund it forever. We've given you all the evidence. You have to pick this up now. And luckily it's been picked up, but it shouldn't have been that difficult. That groundwork should have been prepared from the beginning. So I would just say, think about the incentives. What are people getting measured on and paid to do? Hugely important. Thank you. Claire.
So I'm going to slightly do the workforce bit, but put it into training. So Jay, that's here today, is one of our, we have National Medical Director Clinical Fellows. And the way, the training that they have gone through is probably not that dissimilar to the training I went through many, many, many years ago. And so we are still training, and I'll just use the doctor example, doctors, for a world that doesn't exist currently and won't exist in the future. And we have a bit of an existential crisis going on, don't we, amongst the doctors in the room, amongst our profession. But at the heart of that is that what makes you a doctor and why is that different? But at the moment, we are not training people. Some of our specialties will change and be unrecognisable. You think about radiology, you think about some sort of... any number of the specialties are going to be impacted enormously, but the exams don't reflect that. We're not being trained to consult remotely. We're not being trained to run teams. And I think although we talk about the current workforce changes, I think we need to go back sooner. Otherwise, we're going to compound the issue that we've got.
Yeah, absolutely agree. Ming.
It's not normally a topic I enjoy, but I think the whole risk assurance, governance and regulations are kind of interlinked. I think there's an opportunity with the health bill that's going through now for us to really re-look at the whole data sharing governance frameworks so that we streamline it once and for all. And that is going to need significant work from our department colleagues, but all local systems will need to do that because the way the NHS works, everyone flows through Why is information governance so difficult? It's because everyone interprets it slightly differently. There's an opportunity with the bill to make that much cleaner, but every process and every system is going to need to align to that. And to Sarah's point about incentives and to Claire's point about training, if we don't get that, all the digital funding in the world isn't going to get your programs through.
Thanks, Ming. And lastly, Tom?
Electronic health record integration. I mean, I think an international problem, but every single piece of transformation that we've done has proceeded more slowly because integrating with electronic health records to access data and feedback data back takes far too long. You know, it takes 2 years to get those integrations over the line. And they obviously have to be done safely, it obviously has to be done correctly, but it shouldn't take 2 years. And I think that's holding back us being able to improve care for patients. I think it's holding back a key sector of our economy, and I would really like to see more action to accelerate that process.
Thanks, Tom. So, incentives, workforce training, risk and regulation, EHR integration. It's a really good list. We're out of time. I'd like to thank our panel, but particularly thank Claire for doing a double shift. Thank you, Claire, for that. Could I actually thank the panel? Thank you.